Hey, good morning. So today's topic of CME Chapter 5 will be presented by Dr. Amira and also supervised by Dr. Rahul. The topic is pulmonary hypertension and symptoms. So we should start now. Okay. Dr. Amira is yours.
Hi, very good morning and assalamualaikum to everyone. Today we will be discussing about pulmonary arterial hypertension and also chronic thromboembolic pulmonary hypertension, CTA. So by definition, pulmonary hypertension is defined by mean pulmonary arterial pressure that's more than 20 millimeter mercury at the rest. Prevalence about 1% of the global population, and cardiac and pulmonary is the main causes of the pulmonary hypertension. The prevalence is higher in the individual with the age of more than 65 years old. It's divided into 5 groups. Group 1 is pulmonary arterial hypertension. Subgroup with idiopathic, hereditary, associated with drug or toxin, associated with connective tissue disease, pulmonary portal hypertension, HIV infection. Group 2, mainly associated with left heart disease, for example, heart failure, valvular heart disease. Group 3, associated with lung disease or hypoxia. Example is obstructive lung disease, emphysema, residual lung disease. And group 4 is pulmonary hypertension associated with pulmonary artery obstruction, such as chronic thromboembolic pulmonary hypertension and others pulmonary artery obstruction. And group 5 is pulmonary hypertension with unclear mechanism. So clinical presentation, initially patient will presented with dyspnea on exertion or sometimes complain of fatigue and rapid exertion, dyspnea when bending forward, palpitation, hemoptysis, exercise-induced abdominal distension or sometimes syncope. It's in a rare symptoms, patient might have exertional chest pain or hoarseness of voice. In a patient that have rare disease such as Alzheimer's syndrome, which the aortic is enlarged and compress the left laryngeal recurrent nerve. That's why patient will develop hoarseness of voice. Aortic artery. So this is pulmonary artery. So diagnostic algorithm for this patient, usually patient will came with unexplained exertional dyspnea. So our main first line physician is GP. So it's important to have a really good medical history, physical examination, and ECG to look for any arrhythmia. Pro-BNP if you suspect cardiac cause, and oxygen saturation if you suspect lung disease. So it's divided into lung disease and also cardiac disease. So if we suspect it's a lung disease, we might proceed with lung function test, ABG, chest X-ray, CT scan, and cardiopulmonary exercise test. If we suspect this patient have a cardiac disease, we might have to proceed with echo lah. So with a patient intermediate and high probability of the pulmonary hypertension, we might to refer to pulmonary hypertension center that require invasive assessment. But if patient has low, we might to look for other causes of pulmonary hypertension and manage accordingly. So this is a diagnostic I explained just now. It's divided into blood and also imaging. We send all the basic blood investigation to rule other causes and pro-BNP. The imaging, we do the ECG to detect any arrhythmia, chest X-ray to look underlying causes of pulmonary hypertension, whether it's related to lung or cardio, and pulmonary lung function test and ABG. Echo to look for RV and LV function, valvular abnormalities, and also estimated systolic pulmonary arterial pressure. Chest CT, we can do CTPA or DSA to rule out the CTAF, and cardiac MRI to assess the atrial ventricle size, morphology and function. Ultrasound abdomen to rule out portal hypertension or liver disease. For VQ lung scan, we are to rule out CTAF, and the gold standard for diagnosis and classify the pulmonary hypertension is right heart study. So we're focusing on pulmonary arterial hypertension. It's hemodynamically characterized by precapillary pulmonary hypertension in of other causes of precapillary, such as CTEPH or pulmonary hypertension associated with lung disease. So in systemic sclerosis, prevalence is high, about 5 to 19%, and some mutation carrier have a lifetime risk developing pulmonary arterial hypertension, about 20%. So estimated about 1 to 2% patient with liver disease and portal hypertension will develop portal pulmonary hypertension. So mainly the pathophysiology of the pulmonary arterial hypertension is because the pulmonary vasculopathy that lead to increase the vascular obstruction and lead to right heart failure. So for severity and risk assessment, to evaluate the severity of the pulmonary arterial hypertension, a few panel data required, including clinical assessment, symptoms and functional class, WHO functional class, exercise test, 6-minute walking test, or we can do the cardiopulmonary exercise testing, biochemical markers, BNP, echo, and also hemodynamic evaluation is right heart study. So this is the WHO functional status. It's similar to NIHA lah, which WHO functional class 1 is because patient has no limitation with simple activities. Class 2 have slightly limitation. Class 3 market limitation, and class 5 unable to carry any physical activities. So this is risk stratification at the time of diagnosis. This to rectify patient, to estimate the prognosis of patient, to estimate the 1-year mortality of the patient. So in the time of diagnosis, we have to do all these parameters to classify patients whether patient have low risk, intermediate or high risk. During the follow-up, we will use the risk stratification 4-strata risk assessment tools. These include the WHO classification, 6-minute walking test, and also pro-BNP. It's different from the diagnosis, we are including the right heart study, but this one for follow-up, we need to, it's just clinical and also biochemical. For therapy, therapy for pulmonary hypertension, general measure, physical activity and supervised rehabilitation shows improvement and significant improvement in patient with PAH and also CTAF. For diuretic and restriction of fluid intake is recommended if patient start to have the right-sided heart failure and also edema. Cardiovascular medication, this medication had a potential dangerous drop in the blood pressure, heart rate. So we need to be cautious in using the cardiovascular medication. Anemia and iron status in patient with PAH, iron deficiency is associated with impact myocardial function and will aggravate the symptoms and also increase the risk of mortality. And vaccination is recommended for this patient. So for therapies, calcium channel blocker, PAH is during the right heart study. Sometimes we do the vasoreactivity testing. If the vasoreactivity testing is positive, it shows that it's more response to the treatment of CCB in high dose. So for follow-up, we need to assess the patient after we start the medication. We need to assess about 3 to 6 months after the therapy to see whether ada improvement or not. So the continuation of high dose CCB is recommended in patient on idiopathic, hereditary, drugs, or drugs pulmonary arterial hypertension in the WHO class 1 to 2. And for the patient that doesn't undergo the vasoreactivity or negative test result, we not recommend, should not start the CCP. So therapeutic target, there we have three pathway: endothelin pathway, sodium nitrite pathway, and also prostacyclin pathway. So for endothelin pathway is endothelin 1 bind to endothelin receptor A and B in the smooth pulmonary artery smooth muscle and promote vasoconstriction and proliferation. So what it does is with endothelium receptor agonist, we prevent the vasoconstriction, because we know the pathophysiology of pulmonary arterial hypertension is because of vasoconstriction that can cause that lead to right heart failure. So for example of endothelin receptor antagonist is bosentan, mesasentan, and also ambrisentan. The second pathway is nitrite and CGMP pathway. This one is to increase the activity of CGMP, and because the CGMP will lead to result in vasorelaxation and inhibit the platelet aggregation. So we use the phosphodiesterase 5 inhibitor to stop the breakdown of CGMP. And for example, sildenafil. And another one is soluble guanylyl cyclase stimulation. So next is prostacyclin pathway. This one is to increase the CAMP that result in vasodilatation, inhibit the platelet aggregation and relaxation of the smooth muscle. Example is tripocylin, verapostine sodium. This is the example. There is a trial named Triton trial, shows that if we previously we try to start the medication one by one during the follow up, but in this trial it shows the improvement if we start three medication in the different pathway straight away. It shows that with the triple therapy, the patient with an event is reduced compared to single or double. Next is there is another medication, another treatment came out. It is sotatercept. Sotatercept. So this one is a new drug juga that shows improvement in the exercise capacity with a patient that already on the other three drugs. This is the fourth drugs lah. Okay, next is chronic thromboembolic pulmonary hypertension. The incident occur about 0.6% of all patients with acute pulmonary embolism. So when should we consider CTAF is when there is a radiological sign that suggests CTAF, or the echocardiogram shows the systolic pulmonary pressure more than 60 millimeter mercury in the echo. Or patient with persistent dyspnea despite after post-PE, also we have to suspect CTAF. Or in patient with asymptomatic patient, if patient have high risk of CTAF, we need to screen for that. For example, patient with permanent intravascular device, inflammatory condition, essential thrombocytopenia, splenectomy, high dose thyroid and malignancy. So with patient with symptoms after a workout, and also patient suspecting of CTAF in a pulmonary embolism has a risk factor. I mean, during the investigation for pulmonary embolism, we did do the CTPA and also sometimes echo. So in the initial presentation, if patient we think that patient have highly suspected of CTAF in the initial acute presentation of pulmonary embolism, we need to do the perfusion imaging like VQ scan to look for any mismatched perfusion defect. and also another echo to assess the hyperbarometric of the pulmonary embolism, the pulmonary hypertension. Then if we think patient is highly suspecting CTAF, we have to refer to the pulmonary hypertension center. And then we will proceed with right heart study and also CTPA plus DSA. So this is the radiological finding for patient. So CT pulmonary angiogram, we can see the evidence of chronic pulmonary embolism and evidence of pulmonary hypertension. So, for example, the evidence is vascular defect, abnormal wall thickening, abrupt vessel tapering and stenosis, calcified thrombi or collateral vessel, and dilatation of the bronchial artery. For evidence of pulmonary hypertension, right ventricle dilatation, right atrial dilatation, fluttering, and also a pulmonary artery dilatation and mosaic attenuation. For the dual energy angiograph and also digital subtraction angiography is mapping iodine. Is for us to see the lung perfusion, and also it will increase the diagnostic accuracy of the CTAF. And the VQ scan, if the patient have CTAF, they will have the VQ scan mismatch, which occur when a ratio of air entering the lung to the blood flow through the meaning is air that entering the lung with compared to the blood flow in the lung is not mismatch. It's not proper match lah. So we have to suspect the patient have CTAF. Treatment recommendation, treatment for CTAF is lifelong anticoagulation. As for now, the choice of drug is vitamin K antagonist, because the DOAC is a lack of evidence effectiveness lah. That's why kita still lagi proceed dengan warfarin. So in the CTAF treatment, we are including the multinodal approach for this patient. First is surgical approach. It is based on pulmonary endarterectomy, PEA, which we target the proximal lesion. Next is intervention, is a balloon pulmonary angioplasty. We target the distal lesion, and for medical therapy, we target a microvascular. So all the patient need to regular follow up and investigate assessment about 3 to 6 months after the intervention. So this is what I'm saying. PA is more towards the proximal. For BPA is more towards distal, and for the microvascular, we need the medical therapy. So what is medical therapy for this patient? Is one of it Risiguat that's improved 6-minute working test and reduced PVR by 31% after 16 weeks of therapy. Next is tepostiline that's improved the 6-minute working test in 24 weeks. And misatentan is misatentan will improve the PVR and also 6-minute working test in 16 weeks. For other medical therapy is sildenafil and also bosentan, but this is we use as a off label lah. Oh, okay. That's all. Thank you.
Your chair. You are supervisor. You take over.
No questions, right? So so basically the diagnosis lah kan. So the diagnosis must be from
History itself.
So and this diagnosis has moved in many years.
Yes.
So now they have decided that it's at 20 right?
20 or drugs, Kevin Betancourt.
Yeah. But previously they're 25. 20 to 25 is something else. 20 to they divided into so many, but now they have decided that the ESC has decided and 20, because there's always this other classification, which is there has to move from APN to BCAPN or something else. Let's see how there's other classification, the other group that comes up with the classifications. So that's one, and of course the commonness is going to be either from lung disease or heart disease. Yeah. So the rest are quite rare. That's the one. But we have to always be alert, about whether could this be a primary or hypertension. The other group that is quite common is what the systemic sclerosis, and that's the other main group that we have to think about. So, so we have to consider whether in these patients, whether do they actually come in the shortness of breath with the other group or hypertension. The sickle cell is the other one, which is quite common in vaccine, especially sickle cell. So it's not the more obvious ones. So I mean the treatment per se. I mean, how many of us do reversibility? Yes, okay. So sometimes the molecules one yeah, the calcium channel blocker just for the but we know that, like I said, they have reversibility. So
we don't do reversibility because so question to you is of the pulmonary arterial hypertension, which is already rare, how many percent actually show reversibility? Pernah cakap tadi? I gave you the answer in discussing. So 1 in 10 only. So 10% only show.
Okay.
And then of those who can respond, how many can tolerate the doses that are recommended for calcium channel blocker? The start before. We're talking about not being 10, not your hypertension dose. It can go up to 40 milligrams, for example. And look at your the thiazide dose up to 360. So how many people can actually tolerate? If you've seen enough PAH patients, you know that systolic BP hardly reaches 100 sometimes. So that is the main issue as we struggle with the calcium channel blocker. But there's a new Japanese paper that came out saying that there is still some benefit. And we also cannot forget that sometimes they are purposely not doing calcium channel blocker PSS plan reversibility because they want to sell their other drugs. Because their drugs are like but we cannot forget the data that has shown when a patient responds to calcium channel blocker versus a patient who doesn't, mortality for those who don't respond is like that now. They will die. Whereas calcium channel blocker responders, almost close to 100% survival. So that's why some people still pursue but the yield is so low that sometimes it's worth it or not. And banyak kena buat dengan reversibility testing. You've not touched on it, I think it's very technical, but there are some things you have to do when you do reversibility testing. You have to check the pressure go down without compromising systolic blood pressure, for example, to what degree so to ada dalam buku okay? Not the easiest to do.
So sometimes you can just try. They respond, they don't respond.
Will just give calcium channel blocker. And not wrong before they said to us, they just start calcium channel blocker. And if the patient not respond, then but about time to go and assess for other things.
Okay, so those are the things. And then of course then you have your expensive drugs, which is the cheapest is going to be your sildenafil. So that's the options. I mean, in reality, that's the options that we have. Yeah. So it's your sildenafil, of course, that's the dose that you can try. Okay. Then of course the others are expensive drugs. Yeah. So which is beyond our budget, so a bit difficult. Although, so it is basically, your options are either going to be a calcium channel and your sildenafil. Then after that, you have all the more expensive drugs. So of course, then you show your trial and you can have 3 drugs all together and stuff like that. And you can't afford one, maybe for 3, right? And you have your set that's there, which is again how we actually going to
It's what class?
So 4 class, I can't remember what the name of class. But again, it's only study tak lagi.
and they add on therapy. So it's like our basic one. It's a class of our basic one.
Cannot be used as a single.
We don't know the specific from studies.
I think what I mean,
For example, patients like pathological patient, systemic sclerosis or RA, sometimes they develop this pulmonary fibrosis and then subsequently pulmonary hypertension. So in terms of grouping according to the definition, would you put them as at the lung disease or group 5 only? Because in terms of management,
Three or group one.
group 2 or 1.
So that means they've got the lung disease already. So normally it's like
So we will take it as a lung disease.
no. So they've got the lung disease already. But is it wrong for them to also have overlapping PAH? No.
Yeah.
So then the question is, you worried about starting therapy because they're group 3?
Yeah.
Because they're group 1. So you should still start therapy because they're group 1.
Because the data yang for systemic sclerosis, dia orang memang systemic sclerosis. Dia bukan in group 1. Dia memang in systemic sclerosis. That means this systemic sclerosis, they can be group 1, group 3, group apa lah. Nanti dia tengok patients with systemic sclerosis. So dia tak divide it to the group. Dia ambil the disease that
So being in group 3 is not a contraindication for medication. But the possibility, if the possibility of group 1 is there, then you should start the medication.
Macam group 3 pun they have now, so we go down the lines of accident and those rather than trying to go on to
Where we have issues is when you refer to us, you ask us to decide whether it's group 1 or group 3 on that study. And I will normally tell, like I told you guys, I cannot answer you. Because the job of a right study is to make sure it's not group 2, number 1. Okay, so just make sure it's not group 2 first, it's not a heart disease. And between the 1, 3, and 4, that's not for the right study to decide. Although I think you have mentioned once that PAH normally very high cardiac pressure, whereas group 3, a bit on the lower side, but it's not absolute. So that's why you cannot 100% tell people that this is group 3, this is group 1, based on my understanding. So they have to be very clear.
you can just start that if they start with a resident.
Correct. They didn't need the heart to decide sometimes, but for objective measurement and actually gold standard is you start therapy and check back in 3 to 6 months the right heart standing on as well. To check whether the pressure is equal down. The practicality of that is equal to down.
So this
See that? You got it.
so surgery is out of the for treatment lah kan.
So surgery is send it to San Diego. No, but Rais wants to start balik. I don't know, he's not exposed to that. But then they want to start balik. So Gita and all that are trying to re-establish that network. But we'll see how it goes because they're also sending Theo over for BPA training one more time. So at least all 3 are somewhat possible, but we'll see when it actually kicks off. I guess.
Because I mean, basically you have to have a surgeon that wants to plug out every single, so which is crazy.
That's considered curative after the remove, so it's cure from the disease and then we can start.
Yes. But I still don't understand whether would you still not wafferize the patient?
Yeah.
No, you're still right? So that automatically wafferize regardless if you put out every single clot in there because of the predisposition.
Yeah. And then whether the data that shows that if you wafferize the patient and you wafferize plus surgery,
So currently, go back to that one. The rule of thumb is wafferize or rise. And whenever possible surgery, yes, it's better. That's what the data shows that. But obviously, you need proximal lesions. You must want to go and block the distant lesions. When surgery is no longer an option and there is evidence of distant lesion, second line should be balloon pulmonary plasty. At least improve it better. Third is biomedical therapy. Now in Malaysia, we don't have 1 and 2. That's why we run to 3 straight away. And 3, yes, we use squat semua tu ada data because that's the one with the most data. But actually, practical sense, whatever you will use for group 1, you can use it for group 2.
So I think we are a bit sort of one. I mean, we are thankful that it is rare. Second is that we are tired because we don't have much options to give the patient. So unfortunately, when you go to all the unfortunately the rare diseases the drug cost is higher and higher. So any other questions?
Sometimes when we do a right heart study, sometimes we are in dilemma that's mix pre and post capillary mix. Boleh lah kan? I mean, so how do we pursue that in terms of
So your
mix? Let's say the wedge is high, what is the post capillary? On top of that, the BVR is also high, but not too high. It's like more than probably 2 point something, not like 3. So how do we still need to go towards the investigating the lung?
actually there's another formula kind of you can use and subtract something to subtract something. Whether it's gradient depletion or force, which I have. But I have no answer for that. They mix so treat the left and the
That's
right.
the thing. So it's complicated, right? If it's left, it's left. Unless you have this suspicion that it's still going to be PAH, but the other penyakit systemic sclerosis covered. And I understand because kadang-kadang systemic sclerosis, they also have hypertension, they also can get cancer juga. But again, you're still treating the left because you have evidence, you really advance and tell you sometimes you are told that this have that covered. But like systemic sclerosis are going to be predisposed. And the pressure doesn't come down after you treat the left. By all means, start lah, your PAH meds.
Can you treat what you can treat? Yeah. So sometimes you just have to be a bit more I know I have maybe more options. Yes, the treatment. You jangan cari a drug that can treat both. So you do it as 2 separate entities. You have more drugs that can moderate this space. And if the pressure after that, this pressure is still high, then you have not to treat this one because you've given your best bet on this one that treat, right? So sometimes you just have to be pregnant. Yeah. Okay. Anything else?
No question from online.
Because disease is rare. Because that's susah.
Let's go on to the disease.
Memang it's rare, it's quite rare. It's a part of disorderly juga.
Ada question.
Sebab kebanyakan patient yang pulmonary hypertension is because of left heart disease, not PAH. So it is rare lah.
This one presentation.
What about the raw spiral and ditch? That's for right heart failure, not for the PAH.
Yeah.
Goodbye, Shafiq. Done.
What about the role when I did
So wherever possible, warfarin because it's the strongest evidence. It's a lifelong commitment anyway, so get used to the INR checks. We don't have evidence for no diseases progresses susah nanti. So to me, I still use warfarin so far. Tak ramai CTAP lah, alhamdulillah, tapi we use the warfarin. Unless betul-betul logistically problem, then off-label use with an off-label.
It's whether you, I mean, the thing is whether you are suspecting it or not. And you have a patient that, like, you are pregnant, they have, then they have some other event or shortness of breath after that. And whether you're thinking of this is recovery, please, whether instead of whether do you actually have time to think about that to come up with the diagnosis? You tahu from the history, they have shortness of breath, they have there's so many things that will make you at risk of having multiple organized around everywhere. Yeah, but how many times do you actually tell that? How many flights have you been on in the last 6 years? We assume that every single long flight you have, you might develop some kind of migrate or micro. We don't know that, so sometimes it's very hard to do you suspect this is that. So it's one of these where I have to say that the people that have worked out for them say that IGN do is much an exclusion. You rule this out, you rule that out, you rule that. The last thing that so can you rule out P1 and CTEC, then you can do whatever test you have to do just to rule out those diseases, and then suddenly it comes back, so it is not, you don't suspect the CTEC to me, in my opinion. treated. Yes, mana belum masuk dia, I think you see that. I don't think so, unless there's a secret something that I miss. What do you think?
No, I think most of the time it's a diagnosis of exclusion.
Yes, yeah.
And most of the time we don't think about it, although actually we should think about it because from your PE, if you ever had a PE diagnosis, how long does it take before you can develop CPAP? Anybody knows? What is the recommended? 3 to 6 months. Even as short as 3 months, you got. So if you just had a PE episode and your echo doesn't show resolution, or in fact your symptoms are still persistent, actually they are recommending for you to think about CPAP already at that point in time. Then you should go down the line of having to do all the fancy tests. And the other thing is, for example, patient about that, you're going to act more, that patient on CPAP actually can. It wasn't an acute thing because we guys tried to trauma.
Yeah, it's a chronic.
Yeah, it's chronic because you tried to start coming up, and then when you did the CT scan, you saw all the changes that you saw on CT
So
scan.
you have to dilate that, right?
Dilated, calcified, semua. So actually, that's how quick, even in the young patients, symptom taklah berapa lama sangat can develop into CPAP already.
So I think the most important thing is just like amyloidosis, and you have to be better. You have to be aware. And only you will pick it up. First of all, you have to have the knowledge, right? And then you have to be aware. Then you have to be aware and you have to be in tune. Yeah, but sometimes the downside is when you have other patients to see that you go out of tune with the patients. So one of these, so it's like something like you have to suspect why this patient is still breathless. Even have thrown everything, he's still breathless.
Okay.
And the recording it belum.
Okay, thank you.
So next week is me or swab. Back to this bag.
Nanti tak? I can
Oh yeah, itu kan.
let me do lah. Actually, no, actually, you want to,
Because I have so next week.
because after kita tak boleh kan,